on. So although she's been wearing a compression stocking, as this new lymphangioma's developed, it's not been adequately compressed, and so it's been allowed to develop. So what we needed to do with her was put extra, wear made to measure stockings, but she had extra compression in the shape of a little pad that went just exactly over that area that she could just tuck down inside to improve that. So she had made to measure stockings on, when I first met her, she had a made to measure on this leg and an off the shelf one on this leg because there's not the shape distortion, but she actually found as she got older that the made to measures were easier to put on. So in terms of promoting her independence, she ended up with made to measure stockings just because the fabrics got different properties. So they both did the right job for her legs, but she could put them on independently.
So these papillomas are fairly diagnostic of lymphedema then, are they?
Yeah, you don't really see them in any other condition that I'm aware of.
And how many years development would this be?
Oh, that's 20 years plus.
Long term,
Yeah. And this is another lady, and obviously you can see her papillomas.
Gross
and
papillomas.
They're much worse. And the other thing that she demonstrates really well is this thickened brown skin that just comes off in plaques almost. This is hyperkeratosis, and that's another feature that you see in long-term skin changes if they don't have appropriate skincare management from the beginning.
So keeping the epidermis moist and things prevents this hyperkeratosis to some extent.
And you're just looking at bland, unperfumed moisturisers, nothing fancy. You know, things that people can buy, you know, from the supermarket in the initial stages. Obviously, once they get to this stage, they're needing something else. Like you could either use an ointment that got salicylic acid in it to try and just break down the plaques there, or even just 50-50 cream, which is like a 50% white soft paraffin and 50% liquid paraffin mixture. And you can get that either as an ointment or as a spray which goes on. So if a patient's got areas like this where you need to be getting the moisturiser in all the nooks and crannies, sometimes a spray is actually better, or something that's very liquid that will just percolate in. Because if you use an ointment, chances are you'll get a blob of it that goes across the top, but actually doesn't get in and down between.
And if this had readily debride, I suppose you'd take it off during dressing changes.
And quite often it just comes off while you're washing the limb. Yeah, just with normal hygiene.
Certainly very grossly swollen. Quite a lot of inflammation here.
Yeah. And it was just inflammation.
It doesn't look like the angry red inflammation like you get with the cellulitis.
No.
Does it feel as warm as you would get with the cellulitis?
The inflammation?
Yeah.
No. That you don't really feel any change in heat in those areas.
Right.
And again, that can be, if you're not sure, that can be a telltale sign is whether there's heat or not. Having said that, you do sometimes see patients who've got a cellulitis and you're picking it up so early that they've not got the heat there.
Hasn't developed yet.
No.
So it really is a clinical judgment skill, isn't it?
To
work out when there's infection and when there isn't.
Yeah, and some patients will say that 1 minute they felt absolutely fine, and then maybe a quarter of an hour, half an hour later they started to feel unwell. They'd take the sleeve off or the stocking off and their arm or the leg will be bright red, maybe spotty, but very painful. And they can feel quite flu-like. You know, it can really knock
they get systemic features of sepsis and pyrexia, and I assume
and rigors in extreme.
And again, a leukocytosis and all the other infections.
Yeah.
All right, so pain's a useful indicator as well. Then increasing
absolutely.
pain.
Yeah.
I mean, how would this feel in an uninfected state? I mean, what would the patient complain of, feeling wise?
This lady complained again of just the heaviness and the aching, a dull ache. But she didn't complain of an awful lot, but she's actually a lady with Alzheimer's and she's not very easy to assess. No, you kind of have to go with her general behaviour, and if she's acting out of character, then maybe there's something uncomfortable and distressing her.
It's amazing how much skin can stretch, isn't it?
Oh, absolutely. Yeah.
I mean, it's just staggering, isn't it?
Yeah. I mean, we've got a slide coming up where the skin is stretched and then being knocked, and then fluid can pour out as well, like because it's under so much tension. Yeah,
increased interstitial pressures.
Yeah. Now this again is showing you the hyperkeratosis, but look, you can see that
just come off.
Bits fall off all the time. So when you're washing, if you're washing and giving it a bit of a rub with gauze, because it's not fragile at all. You can just rub it with some gauze or a face cloth if they're at home, and bits will just fall off with appropriate moisturiser on top.
So is this papillodemas?
Yeah, papillomas all over the place.
Sorry.
Yeah.
Papillodemas in the eye, isn't it?
Yeah.
Papillomas, yeah.
Yeah.
And what's this sort of?
And that's just dry skin.
Right.
There's nothing major there. He just needed to. What I quite often find is that with men, they don't like to moisturise. They don't see it as something that they would want to do.
Yeah, yeah.
But it's just as important for them as it is for women.
This looks quite inflamed to me. But that's just the
inflammation
chronic
caused by the
chronic lymphedema.
Yeah. I think it looks more red on the photograph than it actually appeared.
Right. And
by eye.
On this limb, to me, this looks like a fairly pure lymphedema because I don't see any venous congestion changes.
No.
So I don't see any hemosiderosis and that vein there's a bit prominent, but I don't see any vein flare or anything. So.
No. And I can't just remember now his original diagnosis. I can't remember his cause of lymphedema. But while in this country cancer is the biggest cause of lymphedema, what we're actually seeing in the lymphedema service is a lot of chronic edemas coming through, either that have lymphedema superimposed on them or chronic edema that we're trying to manage so that they don't develop lymphedema. But cancer's the main cause of lymphedema in this country, but also it can occur as post-cellulitis. They can get lymphedema post-DVT if they get post-thrombotic syndrome and that's not managed. They'll get lymphedema. Any chronic edemas that have not been adequately managed have got the potential to develop into lymphedema. And trauma as well. You know, I've had patients who've had nasty road traffic accidents or quarrying accidents at work who've actually damaged lymphatic drainage routes, and so they will then go on to develop lymphedema distal to that.
Then we've got the iatrogenic stuff as well, haven't we? Surgeons taking out lymph nodes and
absolutely
radiotherapy.
Often that's linked with the cancer patients. Yeah, you don't really see that much outside of cancer treatments.
Right.
Yeah. And this is just to demonstrate again poor skincare. Really, this is a lady who came from a nursing home, and so you would think that when they're in somewhere like that and they're getting washed and cared for, that skincare would be an integral part of that care, but often it's not. So one of my messages to get across is that would all be improved just with a bland moisturiser.
Simple as that.
Yeah. And to do it every day. That's the important thing. You need to have a daily routine of scrupulous hygiene and good skincare in terms of moisturising and skin inspection, looking for signs of cellulitis. And that way they're less likely to get cellulitis. And any time they do get it, you pick it up quick and you treat it.
And again, this looks like a fairly pure lymphedema to me. I don't see any venous features there.
Yeah. This is a lady who'd had, she's been in a nursing home for many years, had dependency edema, which wasn't managed. So there's no other fat cause that I could find for her to develop lymphedema. She's just had chronic edema that's not been managed and she's gone on to develop lymphedema.
So just purely the immobility?
Yeah.
Yeah, that's...
Immobility and inadequate skincare.
It's quite an indictment really, actually, isn't it? I mean, if you've been walked around and given adequate skincare, then a leg would certainly be in better condition.
Yeah, I have to say though, this is a lady who is very strong-willed, and probably whatever they tried to do, she would have.
It was difficult.
If it came to exercise, she'd just say no, and obviously you can't force people to do it. But you know, there are ways of encouraging people to do things. Yeah.
We could use our interpersonal skills, couldn't we?
Absolutely.
Yeah.
Yeah. And this is just to show the chronic inflammation, and this was not infection.
This isn't hemosiderosis then, this brown, it's...
I think in her case that was just chronic inflammation.
Right.
Yeah.
So these are changes to the skin as a result of chronic inflammatory
processes.
Ongoing processes,
yeah. And you can see for her, she's got the swelling due to trauma, and she'd had a knee replacement there, and she'd had one on that side as well. Yeah. And I do see that sometimes patients develop lymphedema, develop oedema after knee surgery or hip surgery, and if it's not managed, it then goes on to develop into lymphedema, and that's what happened in her case.
And how would that feel to palpation there, Andrea?
Very woody, very firm, not pitting at all in her case, just because it had been so long standing.
So the fluid's under there, but there's so much fibrosis over the top of it. It's,
that you just can't make a dent.
You don't get the dent, yeah.
Yeah.
So the degree of fibrosis presumably is a good indicator of how long-standing
it can
the
be.
condition is.
Yeah, because they certainly don't develop that within a short space of time.
So you're talking years.
Yeah.
Yeah.
Usually. Yeah. Now, this is a lady who is on treatment at the moment and has always preferred to have open-toe stockings. So what you can see there is the result, because her toes have swollen up a lot. Yeah. She's also a lady who doesn't take responsibility for her self-care very much. So she'll wear her stockings every day, but as for washing every day and creaming her legs every day, that's a bit more hit and miss. She'll do it sometimes, she'll tend to do it if there's a problem. But I wouldn't expect that someone who's on management, who knows what to do, would come with toes that looked like that.
No, you would hope not.
And with this degree of hyperkeratosis. Yeah. She is a difficult case. She's also a very obese lady who is actually increasing in size, not decreasing in size.
But most of this is the oedema causing this swelling, it's not, rather than obesity.
No, she's got swelling because of obesity,
right.
But it's stayed there for so long that she's developed these long-term
superimposed lymphedema as well,
Yeah.
So that's a
papilloma that's actually been... But you can see how squashed it looks, and that's because she's had a stocking over the top. And those little vertical marks that you're seeing on there are from the knit of the fabric of the stocking. So that when if I take a stocking off and I see that marking, I'm happy with that, because that's proving that the stocking is gripping the skin and doing the work that it needs to do.
Significant skin crease down there.
Yeah, and that's why she's in the flat knit garments that have that weave to them.
But again, no sign of venous congestion there.
No.
I think.
No. But I've actually, with that lady, she's had her legs bandaged once or twice, just to try and, in stages, bring the size down and get her into stockings so that things are not going to get worse. But because of the fact that she's putting weight on and she's not really making much of an effort with the self-care, I've now discharged her, because if they can't do the self-care, if they're unwilling for whatever reason, you're on a hiding to nothing. And so she's had, she's had all the advice, but she's when you look at people who are overweight and you're looking at whether they're actually willing to make lifestyle changes, and some people are in that pre-contemplative stage of thinking about doing something, and sometimes the fact that you get involved can be the trigger that makes them do something about it. Some people are not willing to do anything, and she's one of those.
So health education is a very important part of the role, isn't it?
Absolutely. But you need patients to take some responsibility. Yeah. So now she knows about the skincare, she's got stockings that she can get on repeat prescription, and until she loses weight, she won't come back to the service.
It's a good example of planning care with patients, not on patients, isn't it?
Absolutely, yeah.
And until you've got that agreement between the two of you, it's very hard to move forward.
Yeah, I mean, I've got another chap, and there'll be a photograph coming up of him soon, who was very overweight, and his BMI was 90 something. Okay. Huge. But and his legs were worse than this lady's, but he made a commitment to lose weight and he stuck to it, and so he's made big progress.
Excellent. Very encouraging for both of you, isn't it?
Yeah, absolutely.
Yeah.
Yeah, so you can see all the long-term complications in this lady. This is the lady that we were looking at the back of her leg earlier on.
Right.
So this is the papillomas around the front, and they are absolutely huge.
So these are actually like solid, are they?
Yeah. Well, that one's more watery. You can see it's more thin walls.
Yeah, I was thinking that. Yeah.
That's more of a lymphangioma, and that's more of a papilloma.
Right.
But obviously, at some point there's a fine line between what's what. Which one it is.
Yeah. So we've got the inflammation, got the
hyperkeratosis, got the papillomas, got the deepened skin folds, got the shape distortion.
Yeah.
She's got everything.
Wow.
Yeah, so she's a really complex one, and those complex ones are the kind of patients that should be being seen by a specialist service. I would argue that the chronic oedema ones should be being picked up and could be easily managed by community staff and practice nurses and tissue viability nurses to some extent if they've got wounds.
Yeah, I certainly wouldn't feel comfortable tackling that.
No, and I wouldn't expect anybody else to tackle that. I think that's definitely a specialist need, that one.
So really this is the end, regardless of the initial etiology, this is the end result of chronic lymphedema, isn't it?
Yeah.
This is what you can end up with.
Yeah, absolutely.
Wow. So that's a very good indicator for any staff nurses who want to prevent this from happening.
Yeah, really. If you don't do anything about it, that's what a patient could end up with.
Let's pick it up, let's sort it before we get the degeneration that can lead to this sort of chronic condition.
Absolutely.
I mean, if you just imagine that on your own leg, if you roll your trouser leg up and that's what you see, it sort of brings it to life, doesn't it?
Yeah,
really?
And this lady does find it very distressing. For all she's got Alzheimer's, and whenever we're doing anything with her leg, she'll look and she'll say, "Is that my leggy? Look at that," and oh, it's horrible. Cover it up. Yeah. And even in her advanced years and the fact that she's confused, that still distresses her.
Sure.
Yeah.
Well, I'm not surprised.
No.
Yeah.
No. Now, you can't really see this terribly well. This is a palliative chap with just one leg swollen, but he'd not had any treatment up to now. This is the first time I met him. And this mark across the front of his foot is because he was trying to put some shoes on.
Wow.
And his skin was so stretched and so vulnerable that it just split and it bled.
It was an acute injury, that?
Yeah. But also, from that area now, he then had profuse leakage. So if ever he put a sock on, it was soaking in within a few minutes. You can see how fragile his skin is up here as well, because these are all little spotty areas. They weren't infected, but they were all leaking fluid. And that can happen, particularly if they've got a swelling that's built up fairly quickly. And lymphedema itself usually builds up very slowly. But if they've got an acute onset of swelling for any other reason, the skin can either just split so that they lose fluid between the cell walls, or they can easily injure it and then fluid will just pour out until it's compressed, really.
I mean, before we were talking about how elastic the skin is, and it is, but it takes time, doesn't it?
Yeah.
Whereas if you get this acute swelling, you get an acute
too quick
reduction in the quality of the integument, and you can get these acute sort of injuries.
Yeah, because the skin is so stretched and so thin and very vulnerable.
And that must be fairly painful if it's an acute swelling, is it?
Yeah, that was painful.
Pretty unpleasant, really.
Yeah. But the way to manage the leakage, which was the thing that could upset him most, is to put compression on. And a lot of people are kind of quite wary, and they say, "Oh no, we'll just put dressings on that will absorb that fluid." Well, yes, it will, but you're probably going to have to go in every day and do that, change that dressing every day or sometimes twice a day.
But if you compress it, you're going to reduce the interstitial pressure, which is causing the exudate of the fluid.
And you can stop leakage in most cases within a day or 2 days. Very occasionally they need longer term management, but usually you'll stop any leakage very quickly, and then it's looking at what's appropriate compression to put on to stop it happening again.
It's a good example of correcting the underlying problem rather than just mopping up the immediate symptom.
Yeah. Now, this is looking at cellulitis, and again, this is the same lady who had Alzheimer's, and I went to see her one day, and this just looked more pink than normal.
And I think if we compare that red to, say, this red here, that's obviously an angrier red, isn't it?
Absolutely.
And did it feel warm to the touch?
It did. And
painful?
But no, she didn't complain of any pain. And sometimes you find that in elderly patients, and I don't know why that is, but they'll quite often...
There's probably a degree of ongoing peripheral sensory neuropathy.
Probably.
This reduces the sensation.
Yeah, but she didn't complain of any pain, because I did ask her, and she didn't feel unwell at that stage. But we got the doctor to come in that same day, and she got antibiotics, and it never developed into anything worse, and her swelling didn't get any worse.
I mean, soft tissue infections do respond well to antibiotics, don't they?
Very well.
As long as you get it at an early stage.
You get it at an early stage, and patients with chronic oedema need at least a 2-week course, usually.
Right. So we're treated for much longer than we would normally.
Yeah, just because of the fact that it's so the fluid coming out of the limb is moving so slowly often. That I think that the infections. You can seem to have an improvement after a week of antibiotics, but if you stop them after a week, the infection just flares straight back up again.
And as you say, we're lacking the local innate immune response to some degree because we don't have the macrophage activity.
Yeah.
And because of the reduced lymphatic drainage, the antigens are going to arrive slowly in the lymph nodes.
Yeah.
Where the antigen recognised presenting cells will be.
Yeah.
So the antigens aren't going to get presented to the lymphocytes, so you're not going to get the humoral immunity. You're not going to get the development of the antibodies.
That's right.
As quickly as you would.
Yeah, it's all much more slow.
The whole thing is in slow motion, really, isn't it?
Yeah, and even when it's triggered, it still acts slowly and reacts slowly. Yeah.
Mm.
Now that's a very definite cellulitis. Very angry on the right leg there. Yeah. And this was just a lady that I happened to pop in and see just for a routine follow-up.
I mean, that is an absolute medical emergency, isn't it? She needs antibiotics pretty quick. And
yet, I said to her, "Oh, have you rung the doctors about that?" "Oh, well, no, it's nothing really." And because again, she didn't, at that point, she didn't feel unwell, but I bet she would have if it had been another day.
Oh, yeah.
Yeah.
I think she would have developed systemic sepsis from that. And
she probably would.
I think that's a life-threatening condition we're looking at there.
Yeah. So, again, on the phone, GP out.
Absolutely.
And she had antibiotics, and it settled without any long-lasting effects. Yeah.
It never does any harm to encourage GPs to visit anyway, does it?
Well, no. But they're busy like the rest of us, aren't they? And quite often, you'll always come across some patients who almost need permission to call the GP because they don't want to bother him.
Yeah.
It's like they don't feel that they're ill enough somehow. But it's the potential to be ill that worries me with cellulitis.
Absolutely, but again, it's the health education. Look, if you develop cellulitis, you need something. You need it pretty quickly.
Yeah. I think we've got one more of cellulitis coming up. Yeah, this is a chap who has Parkinson's disease.
Okay.
So again, he's less active than he would like to be, and has swelling on both legs. Left leg worse than the right leg. And again, this was just happened to be calling for a routine follow-up just to see if he needed new stockings and check how things were. And this sort of staining here in the middle is normal for him.
Yeah.
But this redness that's spreading out from it is not normal. Yeah. And this goes back to teaching your patient to be vigilant every day and to recognise what's different to them.
Yeah, that looks like the Longterm staining around there.
Yeah.
And then the acute.
But this is a chap who's quite prone to cellulitis as well, and has had, he's now on long-term antibiotics because of it to prevent it, and it has helped. He's not had near so many attacks of cellulitis.
He's got long-standing features again.
Yeah.
And papillomas there.
Yeah, very typical.
Mm-hmm.
And this is a lady. This I thought the last one was the last one, but this is the last one for cellulitis. A lady with arm and hand lymphedema who keeps dogs and looks after other people's dogs for a living, and one of them just happened to scratch her the day before, and that's the result. Yeah.
So we know dog bites are quite bacterially infectious anyway.
Yeah, but this was just a scratch but from a claw.
Oh, okay, right.
Yeah.
So presumably in most patients, the local immune response would take care of that and wouldn't develop into cellulitis, but because of the immune compromise in cellulitis.
Yeah, that was just the following morning.
It's nasty, isn't it?
Yeah. And again, that's one that I just happened to be calling in.
Wow.
Yeah. So I wonder how many times it happens to patients when I'm not just calling in, and how long it takes them to get to the doctors. Because often by the time I see them, it's sort of a few months down the line after the cellulitis, and they'll say, "Oh yeah, I did call the doctor in." I said, "Did you do it straight away?" "Well, I waited a day or two." Yeah. And how did you feel by then? "Oh God, I felt lousy."
I'm not surprised.
Yeah. So it's getting patients to recognise what is the cellulitis, what are the first early signs for them, and nip it in the bud.
Yeah. And for us as well. Everyone involved in the care of the patient needs to have a...
But some patients, they will know because they feel a certain feeling even before there's anything to see.
Yeah. It's the same yourself if you're starting to get flu, when you just feel a bit off, don't you?
Yeah.
You think, I'm getting something.
So some of these patients are actually advised to keep a course of antibiotics in the house. Yeah. And I would always say if they've had 2 or more bouts of cellulitis within a year, if the GP is reluctant to prescribe long-term antibiotics, which is the best option for them,
just low dose long-term.
But just to keep a 2-week course in the house otherwise. Yeah. And most GPs are happy to do that
Absolutely.
for lymphedema patients.
Yes, absolutely.
Yeah. Now, we've got a few sets of before and after pictures. So this is a lady with dependency edema. I think she'd got OA hips or something, and which she'd been waiting to be replaced, and so she'd been quite immobile while she'd been waiting because they were too painful.
Yep.
And this was the result. So this is before bandaging. We've maybe bandaged her once, I think, by the look of it. She
looks like there's something.
She looks like she's got grooves
yeah.
around there, so I must have had bandages on her already.
Yeah.
But then I think the next picture perhaps shows her after.
Oh wow! Yeah.
Yeah.
Mm.
So and that would just be with a week or two of bandaging just twice a week. Now, it's not a perfect result because you can see here that her bandage is slipped back a little bit from a forefoot, so she's got a little bit of swelling there.
Yeah, on the toes there, I think.
Yeah. And the ankle shape is not perfect.
No.
But up here is what I put that in for, to point out that sometimes if you just bandage below knee, yes, you sort out the problem there, but you might transfer it somewhere else.
Yeah.
So if when you're bandaging you notice that a patient is starting to develop swelling higher up,
needs a full leg,
then they need a full leg bandage, and don't just leave it. Or if you notice that the toes are starting to swell when they didn't swell before, they need a toe bandage, and just add it in. Do what you're doing, but just extend it a little bit, and you'll prevent problems in future.
So once you've bandaged this for a week or two, you can just go on to compression hosiery for maintenance.
Yeah, absolutely, and carry on the skincare and the exercises.
Yeah.
Yeah.
Stop it coming back again.
Yeah.
Yeah.
And this is a before picture of the lady that we all recognise her leg now.
Yeah, I thought it looked familiar.
And bear in mind that has been ongoing for 14 years, I think, when we got involved. Yeah. So if it's that long standing, you're not going to get dramatic results with a few weeks of bandaging. But the next picture shows you how much better they did look.
Really,
Just for a few weeks bandaging.
Just for a couple of weeks.
So yeah. In fact, this is probably after 3 weeks when I think about it. But skin condition much better. All those huge papillomas are much flatter. They've not gone away, and they won't go away. But they're much better than they were. And overall, the shape is better than it was. We're not going to get it perfect on one shortish course of bandaging, and that's all she can tolerate. But what we would like to do with her is go in again and do another course of bandaging later and improve it some more. But sometimes you've just got to let the patient get used to the new shape of the limb, the tissues that reaccommodate to that smaller size and tighten up a little bit so you don't get so much rebound swelling.
It's a major change in the body image, really, isn't it?
Absolutely, yeah. So she went into a flat knit stocking, and then the staff at the care home are looking after her hygiene needs and doing the moisturising. She's quite an independent lady anyway, so she will walk. She doesn't need encouragement to walk. And hopefully she'll improve from that as well.
Good.
Yeah. And then this is a girl who had primary lymphedema, and the scar you can see on here is just a faint scar now because she's about 30 when this is taken. And that was an operation when she was 2 or 3 to investigate why her lymphatics were not working properly.
Oh, okay.
I don't know quite what they did, but she's had this lifelong as a primary lymphedema patient, so you can see her toes are affected here. But she's looked after her skin all that time, so her skin's not really affected.
No.
She's been very active.
Yeah.
I think she had some compression as a child, but once she was a teenager, she just rebelled and wouldn't wear it.
Yeah.
But she's not got those other long-standing changes because she's looked
Good
after her skin and been very active. So, you can do a lot just with simple measures.
If you compare that to the previous pictures we've looked at, there's no comparison, is there?
No. But even so, this was now starting to bother her, and she was starting to think to the long term on what have I done by not wearing compression, and should I be wearing it now? So she decided that she would try with compression, so she got a referral to us, and then the next slide will show the improvement. So the shape is much better, particularly on the left leg than the right. Toes are still affected, but not as much as on the previous slide. And now she wears stockings every day, quite a heavy, high compression stocking, because she is so very active. But since she's had the bandaging and she's gone into stocking, she's had 2 pregnancies, which you would expect that the swelling would get worse just because of the pressure on the pelvic drainage routes with the fetus. and actually they've not got worse because she's been very good at her self-care.
Excellent.
And then this is a before picture. This is a lady with a grossly swollen arm. And then the next one is her with her bandages on.
Yeah.
And then the next one is when we took the bandages off, big change in size. And then the next slide shows her wearing a compression sleeve.
Excellent. So that's the full range of treatment.
Yeah, and
course.
that actually all took place over 1 week.
Wow.
So that's the kind of difference you can make. If the swelling is soft and pitting, you can make a big difference very quickly. Now we're looking at bandage damage for inappropriate application of bandages. And you can see on this leg, that's where the top of the bandage had rolled down and tourniqueted and rubbed and actually broken the skin.
Yeah.
So actually sometimes the treatment